something at least?
25, 30, I think it's 30 now.
30, yeah. And it's been since 2000 for me. Yeah. What is 23? 23 years. Holy cow.
Yeah.
So between the two, we got some knowledge, a little bit to help you guys, hopefully, and some experience. And hopefully, you know, we'll give you a little bit more clarity, even if you're going to see another practitioner, you're in a different part of the world. We are here for you. And well, actually, we just got a question in. So we're going to pop this. We'll start with this question, and then we'll get to others. So, what are your thoughts in this cervix biopsy prior to transfer?
Cervix biopsy. I'm not sure what they're referring to. Why would they want to biopsy her cervix? Do they talk about uterine biopsy?
Yeah. Well, maybe
you
she
know,
can
cervix and uterus are different, huh?
Maybe she can elaborate. Money brings. If you can type it in the chat, if you're referring to your cervix or is it the uterus?
The uterus, the uterine cavity, more likely.
I don't see any comments here, but we'll come back to it, and we can definitely come back to that one soon.
Yeah.
Okay, and then. Oh, okay. Wait, she did follow up on it. Thought in the scratch method.
That's
uterus.
That's a uterine biopsy in the cycle before frozen transfer. You know, thought for a long time to really maybe help somebody with unexplained implantation, maybe recurrent pregnancy loss, certain patients. But the data is iffy in terms of whether it really helps or not. I mean, sometimes we do it, you know, just empirically. We may try things like that, especially in difficult patients where we may have had a couple of failed transfers of really good embryos, you know, with good endometrial preparation, etc. And we may try that as part of it. Or if they're getting, you know, an ERA test, you know, that's really a biopsy or a scratch. Essentially, it's the same thing, but we're actually sending a sample, you know, to actually map the lining. So that would serve as a scratch procedure. So controversial a little bit still, no definite answers as to whether it helps or not.
Okay.
But occasionally we do something like that.
Okay, very good. And let me see if this is, okay, yes, uterus. Okay. Oops, okay. And let me start out. We have a few questions here. Someone asked for an acupuncturist recommendation in Orlando, and this is usually where, you know, we refer you to the ABORM website. If you also know any fertility clinics there, they usually know acupuncturists that they work with, and then I think I mentioned last time I actually went to school in Orlando for acupuncture, so there's an acupuncture school there. There's a Florida College of Integrative Medicine, and there are acupuncturists that, you know, obviously work with fertility in that area, as well as my old professor, Dr. Fu, Hailing Fu. I'll look her up. So she's still practicing. She's a gynecologist from China. But I would say, like, go to the ABORM website, ABORM, like Mary.org. That is the American Board of Oriental Reproductive Medicine. And that's going to allow you to put in your zip code. You can find an acupuncturist that works with fertility there. And they are, you know, specialists there in that area. So so good luck with that. And then if also you're in this area, Dr. Gelman also sees patients virtually. And we do also some virtual consults for patients that are, you know, wanting to do more integrative approaches as well. So we do see, you know, we do have patients we treat in other states and that sort of thing too.
All the time.
Not with acupuncture, but we do other methods.
All the time. And I had a patient yesterday, 2 days ago. Well, in the military. And they're getting transferred to Germany, and they still want to obviously work with us. So, you know, we are just going to work with them. You know, we'll prep them over there. They're doing a transfer. And we can usually, you know, use centers over there in Germany for monitoring because they're, you know, an army base, this particular patient.
That's cool.
And, you know, just fly them back when they need to be here. So, you know, a lot of places will help us out and monitor you, or gynecologists in different states will monitor you, and we'll be able to run the show, so to speak. And then you can still, be remote from us, and then just come down for your procedure.
That's very cool.
Yeah.
Very neat. And I think this whole technology has come about in the last few years where it's easier to do this, and definitely
Without this, man,
Yeah.
we'd be, this is just the best part of this whole thing. I mean, I guess it was the one good thing about the pandemic,
Yeah.
The one good thing was this, the
It
expansion of
forced
this
us
stuff.
into the future a little
It
more.
did. It did some really good things. The ability to have this FaceTime with people anywhere.
Right. Yeah. And as far as another acupuncture question was submitted about, I just did my FET transfer. Can I still do acupuncture during my 10-day wait? And we definitely still treat our patients during that time. What do you recommend for your patients typically?
For acupuncture after they're transferred? I usually, say that if they're comfortable, certainly after the 3-day window there, after the transfer, and they're comfortable still going, and we know it works, and they've been going, absolutely keep going.
Yeah, definitely. It's good for stress relief, circulation, and you don't have to be afraid of acupuncture. It's very safe. It's one of the few safe things you can do during pregnancy.
Very safe, and then you're probably going to reduce their risk for nausea.
Nausea we start treating right away. Yes, even before we get
even
positive.
Before they even get nausea,
yes,
if they're having acupuncture, they're probably not even going to get it.
It's become much. We've seen it where we had a month where we shut down during the pandemic, and we had 5 pregnant patients, and almost all they were like nauseous. One of them vomiting, had to go to the hospital. We're like, we never see that because we're treating it so early on, and we couldn't treat our patients during that time. And we're like, well, this is our informal study here, where we didn't, we didn't do any treatment.
It's true. It makes a big difference. So all of you out there, please do it.
It's helpful. And a lot of times another question was, when is the timing right? Like when you're doing an IUI, we just typically still treat patients twice a week. That was one of the questions, is when do you schedule the acupuncture if you're doing an IUI? And how does it really help? And I think in general, we treat it like a natural cycle almost, because it's like you're still kind of going through their ovulation. You're still, working on those healthy progesterone levels, helping with blood flow, stress relief. All this is still true.
Same thing. Absolutely. I mean, it wouldn't make any difference. You go through acupuncture just like you would if you were doing IVF.
Yeah.
I would definitely.
Yeah, for sure. And we still would do twice a week till the ultrasound shows a heartbeat. That's usually what we do. And then once a week during the first trimester. And hopefully the patient is responding really well to the medication and stimulates very well, and produces really nice healthy follicles. But we try to add in our little treatment methods like electroacupuncture, perhaps just like working with that patient a little more frequently if they are a poor responder or they're having issues with that. So, and we've seen some differences in lining, actually. Some patients have had thin lining. It would be a 1 to 2 millimeter increase sometimes when we add the electroacupuncture. So that's usually done with IVF. But if you are somebody who has short cycles, or you've got, on the thinner side with your lining, definitely incorporate acupuncture. I think it does help. And I wish I had an ultrasound certain days, but I usually rely on the patients to tell us that, they are giving us the feedback when they go in, and it's looking good. So, so that's how it helps. Somebody's asking, how does it really help? I think that's what we've seen just throughout the years. Many years ago, we used to do acupuncture in labor and delivery, and we used to see during labor, actually, the contractions increasing on the monitor when we implemented the electroacupuncture into certain points. And those points are very similar to the points we're doing for fertility. So it helps the baby get the baby in, can help the baby get out, as well. So with those treatment points. So we see it, we're trying to help, in certain cases, stimulate blood flow to the uterus. And then we're not doing those points so much actually after a transfer, or, when obviously we're doing a different approach, and we're, trying to work on more calming and that sort of thing. But we're we're working on, you know, really like helping the body focus that energy down there as much as possible. And we would see that in the hospital too, where when we'd stop the electroacupuncture, the contractions would get further apart. When we would turn it on, they would get closer
Well, that's
together. So it's
pretty
kind of,
amazing.
it was pretty neat.
That's pretty amazing. In China, don't they do deliveries with acupuncture instead of anesthesia?
Yeah, I mean, you can
In Chi-
definitely, we've done that. We've had a patient with a rod in her spine. She couldn't do an epidural. So she actually, you know, requested acupuncture during labor,
Yeah.
and we would do that and move an epidural. And, you know, we work on, obviously, I mean, it's not going to be pain-free, but you can definitely feel it, but it definitely takes the edge off a lot of times. And our goal is always to help our patients, you know, hopefully have a faster labor and not be able to just, you know, stall out or have a C-section, and sometimes that happens. But generally, it was a very positive thing, and also most people just fall asleep. So then they go, oh, are they still going to wake up to push? You know, or like, yeah, they're
Yeah.
still there. You know, but you can see the similarities when you're working with patients who have, you know, endometriosis, or they got a lot of cramping, and they all of a sudden they feel better. It's because those uterine contractions are almost like
Yeah, well,
decreasing.
particularly for adenomyosis,
Mhm.
and yeah, obviously endometriosis too, they go together a lot. But you know,
Yeah.
it causes, you know, because the adenomyosis is really like endometriosis that's not just in your pelvis, it's stuck inside your uterine wall
Hmm.
abnormally, and so it's going to cause these abnormal contractions of the uterus. So, you
Yeah.
know, a lot of these people get pain and bleeding, you know, because of all the abnormal motility there
Yeah.
from that. So, you know, I think acupuncture is a great idea for that, you know,
It's
as an
really great.
adjunct.
Mhm. Yeah, yeah, for sure. And we've had teenagers come in who've had to take morphine in the hospital because of
Yeah.
severe endometriosis pain, and we're able to help make a
Yeah.
difference in that.
As a matter of fact, there was an article, not less, I think 2 months ago, from in the Fertility Journal about endometriosis. How I think it was an Italian study that they're, I guess, really recognizing it earlier in younger women, like teenagers who are coming in with this bad pelvic pain or heavy bleeding. And, you know, his point was you can actually see it if you really, really look for it on ultrasound. Not just
Yes.
if they have endometriomas, you can see these abnormal thickening in certain areas and things, particularly around the bowel, you know, the bowel wall between, you know, in the pelvis, consistent with scarring and things like that that's occurring there. So these patients apparently are getting treated faster and getting either the surgery rather than sort of getting blown off a lot of times. That you know, you're just getting your menstrual cycles. They're going to be painful. They're going to be irregular. You know, and or they
Mhm.
just get put on birth control pills and they never get diagnosed until they show up at our doorstep.
Yeah. Well, that's heartbreaking. It's like
Yeah,
7 or 8 years. I read
yeah,
that's how long it takes to get
yeah. No,
the
it's very
diagnosis.
common to
Hmm.
not get diagnosed.
Yeah. Oh, well, we have a question here. High TSH in early pregnancy. What do you think about that? I guess they're asking like what kind of treatment, or what do you do about it?
Well, you know, I think, you know, you want to sort of adhere to the data that keep your TSH 2.5 under 2.5. So, you know, as soon as you obviously recognize that it's elevated, I would get put on levothyroxine, Synthroid.
Yeah.
You know, try to keep it down below where it needs to be, and, you know, check it every 3 or 4 weeks. Certainly every trimester, you know, is a good idea, but every 3 or 4 weeks for sure if you've had some issues where it's fluctuating like that.
Yeah, that's something very serious.
But
I can
I
definitely,
wouldn't leave it like that.
yeah,
That's the point,
yeah,
you know. So that's something you don't want to fool around with.
yeah. Don't try to treat that naturally. I keep telling people that, like,
No,
it's not a
don't
thing that you have
take
to stop it.
iodine. Yeah, don't take iodine because that'll make it worse possibly.
It's very important. It can cause miscarriages
Yeah,
and have,
you
yes,
got to get treated by a doctor.
yeah. We have a question. What are the chances to get pregnant with multiples with a bicornuate uterus if you're on letrozole and a trigger shot with IUI?
Well, I mean, I guess it's possible in any kind of uterus, you know, depending on how many follicles ovulate. you know, I mean, you know, we're kind of very cautious about that in our practice. I mean, two or more, you know, more than two for sure, we usually cancel a cycle. So, you know, two or less, one or two, you know, maybe rarely a third, depending on the patient. We'll take a shot, you know, but, you know, in a bicornuate uterus, your risk for miscarriage is already a little bit higher than normal. So, you know, you don't want to necessarily incur multiple gestations there, in my view. That's probably not the best idea. But unfortunately, sometimes it happens, whether, you know, you're planning on it or not. I mean, you know, sometimes an embryo might, an egg, and you know, one egg may split. You get up with a twin, identical twin, that kind of thing. You're not going to be able to prevent that. So, you know, you just have to be monitored. I'd say if you get more than 2 follicles on your monitoring ultrasound, I'd probably not go for an IUI or try to get pregnant that month.
Okay. So it's slightly higher with the bicornuate, like
it is. I mean, those that's not one of the abnormalities that would be operated on necessarily, although I think in certain cases where those patients have had recurrent miscarriages where we really think it's due to the bicornuate uterus, there are some surgical procedures for it, but it's not routinely one of the abnormalities that surgery is done for, like, for example, a deep septated uterus where there's an actual septum splitting the cavity, so to speak, where the embryo can definitely implant on the septum. And that's sort of avascular. It doesn't have a good blood flow there. So that can definitely cause a miscarriage or, you know, premature labor or, you know, things like that. They're very high risk for pregnancy.
Okay, that makes sense. We have another question here. Should I be concerned if my husband has a 2.5 for form when average is 4? He's above average on concentration and movement. I guess we're talking about more
morphology.
Morphology? Okay.
No, I wouldn't be concerned. That level, that percentage, it varies all the time from collection to collection. You
Uh-oh, I think we lost Dr. Gelman again. I think the internet's going in and out today, guys. Because now unless you guys can hear him, I don't think I can hear him anymore. Hopefully it's not my Wi-Fi. Let's see. All right.
This thing keeps, I don't know, something the matter with a connection here.
Yeah. Okay.
But anyway, so as I was saying, you know, those morphology issues are going to be variable from collection to collection. So if he collects again a month or 2 later, he could have a 3.5%, you know, normal forms, or, you know, maybe 1.5. You know, it depends on his exposures, what he's been, you know, what he's been doing. Was he sick? Did he have a fever? And it also depends on who's looking at your sample, because that's andrology dependent also. So, you know, 2.5 is not terrible. If the rest of it looks pretty normal, I'd say that's probably okay. Put him on some vitamins, some male fertility vitamins, and do what you need to do.
Yeah, definitely can see sometimes that does help. And then isn't there like a difference between what criteria they're using, right? They're like the WHO and the Kruger, or is it?
Well, yeah. I mean, the Kruger is more strict morphology. So again, it's going to depend on, I think, a lot of it on who's looking at it, and you know, they can request certain more complex analysis on something like that with the Kruger method, or, you know, you could do other testing like a sperm chromatin structure assay to see if the sperm has been disrupted in any way, especially if you're not getting fertilization or if you're having miscarriages. You know, that might give you an idea that there's some male factor issues going on. You know, and then obviously if there's real concerns about the sperm, you have, you know, maybe a urologist look at them, and
Uh-oh. I think we're frozen again. Well, I'm going to wait till Dr. Gelman comes back from the...
I don't know why it keeps doing that.
Okay. Maybe the, maybe the Wi-Fi switching back and forth between something. I don't know. I'm not technically knowledgeable in that.
I have no idea.
But we'll see. But you keep coming back, so that's fine.
Yeah.
We're still good. Okay, so there's a question about BMI. BMI currently over 30. During last 4 weeks before transfer, is it more beneficial to go on weight loss, low carb diet, or to follow Mediterranean diet? And we're going to see what Dr. Gelman says, but I definitely think that we tried for like a gluten-free Mediterranean diet for at least 4 to 6 weeks. If you're able to do that, and a lot of patients do lose weight with that. Okay. Oh, now you're back. Okay. I'm not sure if you heard the question, but we're talking about the Mediterranean diet versus a low carb diet. If someone's BMI is on like a slightly higher end with before the transfer. So, so the BMI was 30, and do you have a particular range that you like to see, like prior to transfer, or?
Well, I mean, 35 or less would be great.
Mm-hmm.
For transfer. So if their BMI is 30,
mm-hmm.
No, it's not terrible at all. I mean, it's definitely acceptable for transfer.
Mm-hmm. Yeah, and the whole thing with sometimes a low carb thing is you can definitely kind of rebound from that, where you're eating, more things that you shouldn't be eating. So I think there's a lot of research on Mediterranean diet. We talked about this a lot, and it is definitely nice to incorporate though as much as you can, follow that plan, and it's naturally beneficial for weight, and especially if both partners follow that. I know this time about the transfer, but even if you're talking about preparing for, a stimulated cycle or doing an IUI or trying naturally, I mean, there's research about when both partners go in the Mediterranean diet, they have higher take-home baby rates. So that's something that we give all of our patients just some Mediterranean recipes, like here's breakfast, lunch, dinner for a couple weeks, just so that you have a good framework and some smoothie recipes and all of those. And that way it's not just a concept, it's actually like, concrete, like, okay, let's go home and do this. And, a little shopping list and all of that, at least to kind of get both partners involved. So if that's, if that's doable, then
ideal.
Yeah. Mm-hmm. And then you guys have awesome nutritionists as well that, in your practice, and a lot of our patients do see nutritionists in addition to seeing you guys.
I'm telling you, they make a difference.
Mm-hmm.
There's numerous cases I've had where people have gotten, frozen blastocysts, where they haven't before seen them.
Mm-hmm.
So, is it coincidental? I mean, or is it really due to improved health and improved blood flow?
Mm-hmm. Right? Yeah, definitely. I mean, you can combine with the supplements and tweaking in the diet, working with the little lifestyle issues like also.
But it takes time. People always have to realize that everybody's in a rush, and we know you are. So are we. We're very anxious for all of you out there. But if we recommend that you get healthier for a few months, or if you've had a failed cycle, maybe it's not the time to rush into another cycle. Maybe, if you're coming to talk to us about what possibly it could be, maybe that's one of the factors, is that you need to maybe take the time now to prepare better for your next one.
Yeah.
So anything we recommend, so if we send you to Marta or Dr. K or whoever, that's part of your treatment. Mm-hmm. It's not, wasting time and, all this kind of thing. We realize, a lot of patients say, I'm getting older. Well, we know that, but we also want you to be successful. We don't want you to do cycle after cycle after cycle and spin your wheels and have nothing mm-hmm. to show for it when you could have done better.
Right. Definitely, I think that's the difference. A lot of clinics don't really offer those services, and I think that's important. We're treating people, not numbers. So there's definitely
right.
Benefits to that. And we have a question about, does a PGD test, is it similar to the NIP test that they do later in pregnancy? Do you recommend both, or PGT should be
No,
enough?
I recommend both. PGT is about 90, well, they say 98%. I'd say probably 95 to 98% probably. And there can be situations where we transfer an embryo that we think is PGT normal, and it turns out it's not.
Mm-hmm.
So, because the PGT only sort of, well, biopsies the outer cells of the placenta, of the developing embryo, and that correlates, with 95% certainty with the actual embryo itself. So there are situations where it's been wrong, and somebody unfortunately will have to have, evaluation from a perinatal specialist, maybe amniocentesis, and certain situations where they may have to end the pregnancy, but I think it's a good idea to do the NIPT test also when you get to your gynecologist, Harmony or Panamera, as a double check. And then, because that's like 98, 99, it's getting fetal DNA actually,
Yeah.
So it's a good thing to do.
Yeah.
So I would recommend you do that as a double check, even though you had PGT.
Yeah, just to be on the safe side of that small percentage where it might not be.
Yeah.
And then, as far as having PCOS, someone says PCOS has discouraged me, and I definitely, I mean, you've been working with PCOS since the very beginning, probably, of people actually understanding what it is and treating it, but I think that, it's worth really keeping up with the treatment, because it can be very frustrating, especially when you're not getting your period and you're not ovulating month after month after month, and you're not losing weight. It's very frustrating. So you do need a good team. And we talked about having a good team approach, if you can, of, reproductive endocrinologists, nutritionists, acupuncture. It takes a village with PCOS.
Your program, I saw you relaunched your PCOS Revolution thing.
We have, the podcast is still on iTunes.
That is fantastic. I mean, you should really advertise that. That is absolutely fantastic. For all you people, check out this podcast on PCOS. It's fantastic.
I got a little behind with it during the pandemic, because our whole scheduling changed and everything. But the episodes are there. They're on Spotify, and they're on in iTunes and all that. And I think, we have a few episodes on there, and there's, many doctors that we interviewed, and nutritionists, and
it's fantastic. You're going to get so much information and support on that. It's great. So whoever that is, ask the question out there. Don't be discouraged. Go on this website.
Free. It's totally free.
And go on that and find out about it. And, there's a lot of women out there. And so make sure you network with the PCOS organizations.
Yes, for sure. And I think just starting out with finding what your body responds to the best. Some patients do need I think diet is probably so crucial, even more so with PCOS. And so starting with that.
So advertise it, because somebody's asking, what is that podcast?
Oh, what is it? Okay, it's called the PCOS Revolution. It's on our Instagram as well. I usually post on Fridays, kind of, it's like a flashback Friday. So we put an episode on there each Friday that we've already done. So it's kind of already there. But Marta had an episode on there too, Dr. Wood also. And I think patients, we actually put patients on there, and they talk about what they went through. And I think we've actually had a few patients get pregnant just from listening to the podcast. So that's a good thing. So you just want to definitely connect with others. And that's a good place to start. There are other the PCOS nutritionists. There's many others that are good. And I think, starting with that, and then going from there, and finding people that are understanding of PCOS. So many people just dismiss it, or they, are not really, not as knowledgeable. So you definitely want to get support around you for that. And you can start young. I mean, really in the teenage years, you can start addressing this for sure. So
absolutely.
So I think we had a question about a colposcopy submitted earlier. Should I do a colposcopy if I have abnormal PAP LSIL before FET? OB says come back in 6 months.
Should she do a colposcopy? What?
Well, she has that low grade the LSIL. So should she do it for an abnormal PAP?
HPV?
I guess I'm not sure. It doesn't say, but it's definitely an abnormal PAP. Should you do a colposcopy before an FET?
Well, that's up to her
Yeah.
gynecologist. I mean, that's really not a question for us. I mean, that's really something you got to share with them. They should be very well versed when to do that, particularly if there's inflammation going on in the PAP and you have HPV. You definitely need a colpo. I'm sure if you really want to have that before you do an FET, it's probably a good idea, just to make sure nothing's missed at the time you get a transfer, God forbid.
Yeah, I think that then the OB says come back in 6 months. So I guess the fear is like, what if it's still abnormal after you do? Do you guys require a negative PAP, I guess, before a transfer or yes?
We do.
Okay.
We do. It can, I mean, if that person had HPV, but no inflammation or atypical cells of undetermined, that's probably okay. But
yeah,
we usually like a clearance from the gynecologist if there's any question. But preferably a normal PAP is what we would require.
Yeah.
But if this patient had any inflammation or anything else going on, definitely needs a colposcopy.
Okay. And okay, and here's the immortal question: when do you choose frozen over fresh embryo transfer?
Yeah, good question. Mostly frozens now. We do a lot of them because there's a lot of things you can do. You can program the cycles, you can program those things, but also the success rates are probably a little higher with frozen than they are with fresh. There are times when I do fresh though, particularly in people where, maybe they have low ovarian reserve, or where we know we're not going to overstimulate somebody, and, maybe they've had a couple of frozen transfers that weren't successful, and now this is their last stimulation, and, maybe we're going to do a fresh transfer this time, where we know we're not going to have to cancel it because they're hyperstimulated or, something like that going on. So there's individual cases where we will do a fresh transfer, but not notably, for the run-of-the-mill good prognosis IVF patient, we'll usually do a frozen. Because most people, I'd say 80% are doing PGT anyway. So you can't do a fresh transfer with that. You'd have to do a frozen.
Okay. Yeah, definitely. We don't see as many patients doing fresh transfers anymore. It's funny. Yeah. And the cons of pregnancy with a bicornuate uterus, I think we talked about this question already, about the multiple risk. And is there any other issues? I mean, I guess the growth of the baby, are you concerned about that with bicornuate? Or?
Well, usually, I mean, I think they got to be watched, because they're higher risk for premature labor. That would be the big thing with that. So, they're going to be under the care of a perinatal specialist and getting, special ultrasounds, things like that, to watch the growth, But bicornuate, I mean, most of the people do fairly well with that abnormality. Again, some of the other ones, again, depending on how severe it is. And, sometimes they read it as a bicornuate uterus, and it really isn't a bicornuate uterus. It's an arcuate uterus, which is a normal variant.
Okay.
So,
no need
again, it depends who's diagnosing you. I mean, there's criteria to diagnose it based on looking at what's called the myometrium, border at the top. If it's indented, in addition to the inside cavity being heart-shaped, then that's probably a bicornuate uterus. But, a bicornuate uterus can look like a arcuate uterus too. You can be confused.
Okay.
Or, so it depends on who's really reading it.
think we've had a few patients that get pregnant with the bicornate
Yeah.
uterus. It's
Yeah.
not very common though, but or do you see it common?
Yeah, it's I mean one of the more common abnormalities of the uterus.
Mm-hmm.
But and septate uterus is probably the other one where we see usually small septums, usually not deep ones. Okay, rarely, maybe one every 2 to 3 years, you'll see somebody with a very,
Yeah.
very deep septum that will need surgery for sure.
We also have a question about, do you have a recommendation when you have mature eggs that don't fertilize? Calcium activation.
What was that?
Mature eggs that don't fertilize. Do you have any recommendations? Calcium activation, gold medium, add hormone or vitamins to the medium?
Yeah, they usually try calcium ionophore for that because if the sperm isn't, I mean, it was natural fertilization, or was it ICSI or what?
Yeah.
I mean, ICSI would be one thing, and maybe calcium ionophore, which is activates the sperm a little bit better to fertilize in there. So that's one thing they definitely would do with that kind of situation.
Okay. And there's a question about fertility tests for men. Question, does it matter if men test their sperm level in the morning or the evening? That's a good question. I've never thought about that. Like, does it make a difference as far as timing or?
Well, I mean, if you're going to do an analysis in our office or any place else, you're going to have to bring it in the morning.
Mm-hmm.
So usually in the morning is the best time for that.
Mm-hmm.
Your hormones vary a little bit in the afternoon, that kind of thing. But I don't know. I guess a home test wouldn't really matter if that's what you're talking about. But, in a doctor's office, generally it's done in the morning, first thing.
Oh. What do you think of those, what is it, Yosperm? And they have like a couple others from like home tests that you can actually connect to the iPhone. I don't know if you've seen them.
No, I haven't seen them. I mean, I've heard that people come in, they say they did a home test. And, basically it tells you you've got sperm present.
Yes.
Maybe gives you an idea of the concentration, but it doesn't really give you much else.
Yeah, and definitely, if it's alarming if you don't see anything on those at all, then you better go. Better get
that?
Out if you don't see any sperm swimming around on those tests, and there's a problem.
Yeah, well, then you got to go. You got to get a professional assessment.
Very cool. Okay, she's saying doctor's office. Thank you. Okay, yeah. So probably, and definitely, if you're not doing it on site, you need to be. I think Quest, or is it Lab? No, LabCorp says you have to deliver it within 45 minutes of creating that sample. So there's like time of the essence with that, But if you're doing it in the clinic, then I guess you have a little bit more leeway with that. But
well, usually they tell them to bring it from home now. They don't encourage doing it there so much.
Okay.
But so most people, get it there within an hour-ish. It's probably reasonable.
Okay, so what is the time limit there? I guess if you don't.
An hour.
It is, okay. Well, that's good to know. So don't get stuck in Palmetto traffic. That would not be good.
Yeah, no, that's pretty bad. No, I mean, we've had people over the years who got stopped by cops.
Oh no.
Yeah, showing us
got an excuse here, yeah.
Yeah. Well, yeah, right, buddy. Write them a ticket anyway.
Yeah. They're like, I've heard of that before. Yeah.
Yeah.
All right. Let's see. There's a question here about day 5 for BB blast after thaw did not re-expand completely. How much does this affect implantation, and what causes this?
I didn't hear that question.
Day 5 for BB blastocysts after thaw did not re-expand completely. How much does this affect implantation, and what causes this? Could waiting longer and medium would have helped? Or
yeah.
Waiting longer.
Well, didn't they wait for it to expand? I mean, they usually do. So I don't know what they did there, but usually they'll tell you that this needs more time, or that kind of thing. So maybe delay the transfer a little bit.
You could do day 6 transfer.
What's that?
You could do a day 6 transfer, right? If you have to.
Yeah, but this was at day 5, and they thawed it out, ready to transfer it.
Okay, yes. afterthought did not re-expand completely. Okay.
Yeah, so maybe it wasn't a great embryo. It wasn't gonna, do what it's supposed to do. It's possible.
Mm-hmm.
Um, Hard to know what that situation means.
Let me see if there's not a follow-up there, but okay, so there's a no about no. Okay. Oh, about waiting maybe? Did they wait? Huh. Okay. Well, that's like an embryology question, right? I mean, maybe we need the embryologist.
Mainly, yeah, that would be good for Inya when we have
Mm,
her back.
yeah, that's good. There's a few questions here. I think that I just saw this one. Okay. Whoops, it's a little long, so I'll read it here. Having a transfer at the end of this month, my doctor prescribed Lovenox starting the day of the transfer up until 10 weeks of pregnancy due to history of recurrent pregnancy loss, MTHFR genetic mutation. Would acupuncture be advised while on a blood thinner? Sure, like we treat patients on blood thinners
Hmm.
every day. There's hardly any bleeding from acupuncture, and you might bruise a little bit, but you are probably already bruising. If you are going to bruise, you're already bruising from the injection itself, from the Lovenox, and from the progesterone shots, and if you're doing anything like that, or even just from knocking your knee or your leg just a little bit, sometimes you'll bruise a little easier. But we actually don't see any increased bleeding with acupuncture and
No,
Lovenox. Yeah.
you're not going to bleed from that.
Yeah.
That's not the major trauma or anything like that.
Mm-hmm. Okay, so that's there.
But that
And,
sounds good. That sounds like a good thing to do.
yeah. And I would say, in fact, like if you need to be on Lovenox, it's probably a good idea to have acupuncture as well, since it does help with a little circulation. So that wouldn't be a bad idea too. So, um, and we have like a few little questions we haven't gotten to in our pre-submitted questions, but we're getting close to the end of our questions. So you guys can still jump in and submit your questions as well, as we still have a few more minutes. Let me get to the ones we didn't get to. Okay. When and how long often should you do acupuncture before egg retrieval, especially with PCOS? And usually, with our patients, we try to see them twice a week. In that 6-week time period prior to stimulation. So if you're able to do that and you're, and you're being diligent with it, if you're treating, I guess, with acupuncture prior to that, usually once a week is fine. But in general, during that time, you're usually uncomfortable sometimes if you're doing, stimulating and your ovaries are getting enlarged, and you're feeling sometimes some headaches, sometimes bloating, mood swings. Acupuncture is great for those side effects as well. And then with PCOS, I don't know, some patients need a little more time, right, on the medications if their follicles are growing a little more slowly. So we work on, helping with electroacupuncture. Sometimes we'll do a little gentle massage as well, not during the stim, but before that, just to help in general with that blood flow and relaxation. And that's what we typically do. And then, also the day before the retrieval, we'll do a face down electroacupuncture treatment to the sacral, or the lumbosacral area. That's a treatment that's actually proven to enhance blood flow by Doppler. And we'll see it, with patients that are, maybe they're on the edge where it's like they just need a little bit more because they have a few follicles that are responding, and then they have a bunch of little ones. Sometimes that's also good. So we try to work on that respect, that with the timing. After the retrieval, we don't see patients usually back until like 3 or 4 days after, when they've had time to rest. But in some cases, when they're still feeling a little bit icky and hyperstimulated, we tell them we can do some acupuncture to help in general. But I think most patients are feeling good after a couple of days. Usually they feel much better after the retrieval when everything's out, and their estrogen levels have come down a little more and all of that. So, so you have any feedback on your patients when they're undergoing acupuncture during stimulation? Have they had any feedback from your patients at all?
No, I mean, every one of them that always tells me that they're enjoying it. Initially they might have been scared of it, but they usually respond very favorably to it. So, I think it's a definite thing that they've got to try to do, try to add to this, very busy time of their life.
Yeah.
It's an extra appointment, but it's an important one.
And we actually have a lot of couples now coming in. So like the partner, even if it's not fertility related, they just want to be more relaxed in general, or they feel like
Of
they have back
course.
pain or neck
Who
pain.
wouldn't want to be?
Yeah, so they want to, have it like a little, it's like a little Saturday date, to do acupuncture and a little massage sometimes. And they both, leave much more relaxed. So I think this whole process can be a little stressful for sure.
No,
And
no
it's,
question.
nice to have that as a break. And again, I mean, most patients, even if they're needle phobic, they're usually falling asleep on the table. I posted an 8-year-old patient that we saw the other day, and she was incredibly nervous because she had sinus congestion, and her mom said, okay, look, just try these needles, see how you feel. And she literally was like completely relaxed with these little, facial points. And most people are terrified of needles around their face. But I just said, look, if you can do it, you're 8 years old. I think everyone can do it. They're really, really tiny, so in general, it's pretty gentle treatment. And then also, I think in some patients who've come to do acupuncture, they've actually desensitized a little bit to that needle phobia when they're starting their injections. So they're like, okay, this is a little easier now because I've been around needles. I'm not so bad with that. My anxiety is a little bit lower. So I think that can actually help a little bit. The biggest needle phobes are in the health profession. That's really funny. The ones that we see, a lot of nurses are definitely scared of needles.
Oh, yeah. Yeah. It's true, because, we're giving it out, but we can't take it.
That's it. Yeah. So yeah, I mean, definitely we've seen that. Let's see. We have a question about, let me just go down here. Okay. What can I do during my last ultrasound before egg retrieval, my follicles were between 16 and 22, but not all follicles were retrieved, and some were not mature even though they were big?
Well, what do you mean they weren't retrieved? They couldn't get them, or there was no eggs in there? Sometimes there's no eggs in the follicles.
Okay.
So, people, think that when we're looking at those follicles, that's the egg. That's not the egg. That's a follicle. The egg is in there in fluid. And, when you have the retrieval, you're sucking out the follicle and you're getting the fluid comes out with it, and the egg should be hopefully in there. But not all those follicles contain eggs, or the eggs get stuck. So, and then there's some patients you can't get all the eggs, or all the follicles. The ovary may be difficult to access.
Mm-hmm. And the ones that were not mature, even though they were big, that's what she's saying. So they were.
Well, maybe next time, if the eggs came out and they were not mature, you're going to have to grow them bigger. Mm-hmm. So you should learn from this cycle that, if the egg, they triggered you and you were 18 or 19, maybe they need to be 21, 22 maybe, mm-hmm, for the next cycle. So you're probably going to have to be pushed harder.
Mm. Oh, they couldn't get the eggs. They couldn't get them, she's saying.
It sounds like the ovary may have been inaccessible for some reason, or difficult to get to.
Mm-hmm. Okay. That is it's a learning process. I know sometimes with us, and it's very difficult because you don't really know what you're going to get till you're in there, right? Till you start in some cases.
Right.
And
I mean, but again, some patients are difficult. The ovaries are difficult to get to.
Mm-hmm. Yeah, that would make sense. Would you see sometimes the ovaries are kind of behind,
or they're high up,
okay,
or the patient's a little bit, has a weight issue or whatever. Sometimes they have to do it transabdominally. Okay.
Mm.
Yeah.
Oh, okay. Oh, that makes sense. And let me see here. I think we have reached the end of our questions, guys. So that's it. Yeah. And we actually got to our pre-submitted questions. So Any advice, any parting advice you'd like to give tonight to everybody going through their cycles?
Well, the issue is, like we've been talking about for years already, is to relax and to be confident, to always to be, cautiously optimistic that, sometimes even the best cycles and the best intentions and the best prognosis patients may not necessarily get the best results all the time. And, that's nature,
Mm-hmm.
you know, and that's why, and I say this in every consult that, it's going to really turn out to be, what you guys give us. That's all this process is. It's what you as a female and your husband as a male are going to give us sex-wise, sex cell-wise, and we're going to put them together as best as we can, best as we know how. But it's all going to depend upon the quality of what you give us. That's why we keep talking about diet and health and, all that, and how much of a role that really plays.
Yeah. No,
so it's very important you follow our recommendations on that, because it makes a difference.
Yeah, well, it's so true. We definitely see it too, like time after time. Sometimes we're optimistic overly and we think, okay, maybe 3 months, and no, it could take 9 months, it could take a year before you start seeing the results of what you've done with some patients. So, and we see it where we get a call like, oh, we just got pregnant naturally, and it's like, and you're on the supplements for 12 months, sometimes it takes that long. And some patients after
hopefully not that long, but I mean, there are cases, where it's taken a long time, but we got to give them, really sometimes a solid few months, 3 months maybe, to really kind of focus on this, and they have to do it. It's something you really should be committed to if you really want to go forward with this. I mean, this is a big expenditure for you. This is a big time commitment, a big, emotional, financial commitment. You want it to work.
Yeah. So, and sometimes those breaks where the cycle doesn't go well and you want to just say, oh, screw it all, I'm not going to take these supplements, I'm done with it. That's when you need it. That's really when you need it, because that's when you start seeing the little tiny little follicles. They're going to start emerging, that we're primordial, that we're getting all these benefits.
Keep your weight down. Keep your weight down. Watch your diet. Don't over, drink and smoke and things like that. Those are the things you really have to be very cognizant of.
And resveratrol, I'm really doing a lot more research into resveratrol lately. As far as, we didn't talk about supplements, but usually we get supplement questions. But I mean, there's many that are out there, but I think we've kind of forgotten about that one for a while. And there was I
mentioned it particularly in endometriosis patients to take that.
Yes.
I think it's important, to take that as part of their plan.
Yeah. It does have an effect on the mitochondria and sperm health, egg health, but I think that's something that we overlook, because you keep saying CoQ10 and, ubiquinone and all these things. But I think those, though they're out there and you want to just kind of choose wisely, but a lot of things, like we give the greens first. That's a great little powder. It has resveratrol.
Oh, it's great. That stuff, and it tastes good too.
Yes, and probiotics nourish your gut as well. Your gut health is going to be really important, because you're going to go through antibiotics. You're going to have stress. You're going to have things come up that are going to be a surprise sometimes as far as findings. You're going to have time, to be able to do these things. So share a little canister of like greens first, or whatever greens you prefer. But a lot of times they do have resveratrol. They have things that you can take with like a fatty acid, and that's going to help a lot too as far as egg quality. In general, nourishing gut health too, with that respect. So we make sure every single patient we see is at least addressing gut health in some way. It's very important, and that can make a huge difference. I know you guys recommend probiotics as well prior to transfer, that sort of thing. So so we can, if all we ever do at the end of the day is help someone's gut out, we're really helpful. I think acupuncture and supplements help a lot with that, but and diet obviously, but people just feel so much better when they're able to sleep and they're eating well.
Well, that's the last thing I'll say is get plenty of sleep. I think that's neglected in most doctors' visits. Is people aren't asked about that enough. And that's a big, big thing, because if you're not sleeping well and you're not getting good quality sleep, you're going to be exhausted. You're going to have a lot more stress.
Yeah.
You know, everything's going to bother you. You know, so it just, things don't go as well unless you're much more relaxed when you sleep well and you're rested, and that makes a big, big difference in terms of your blood pressure.
Yes. And on that note, everybody, I'm going to hopefully have a nice rest tonight. We look forward to the next live because we've actually reached our time. But thank you, Dr. Gelman, as always.
My pleasure. Sorry
here.
about all the audio issues we're having here.
That's okay. Hey, we're going to still blame it on the weather because it's
yeah, it's got to be.
Got to be. And thank you, everybody, for joining us. So we'll see you next time. Make sure to follow Dr. Gelman at Broward Fertility Expert, and we're at FL Complete Wellness. And take care of yourselves.
Take care, everybody out there. See you next month.
Bye. Good night.
Bye-bye.